May I invite Dr. Satya Gupta, Senior Consultant Interventional Cardiologist and Director of SIMS at Ahmedabad in Gujarat. And for the next 11 minutes, he joins us to speak on TVD with low ejection fraction, CABG versus PCI versus medical therapy. Dr. Gupta, please.
I'm going to discuss the treatment strategy in a patient with the triple vessel disease with LV dysfunction. We all know that there are three modes of therapies available for all our cardiac patients, maybe medical therapy, PCI or coronary artery bypass graft surgery. It's not always very easy to select the which treatment is appropriate for our given patient, whether to select a knife or whether to select a balloon. And that too for a patient with the triple vessel disease with LV dysfunction, whether the PCI is better than the optimal medical treatment, CABG is better than optimal medical treatment, or PCI versus CABG. We have data available from very good trial, the COURAGE trial, which compare the patient with optimal medical treatment along with PCI versus optimal medical treatment along. And that was trial for a 5-year follow-up, and they compared that, non-fatal myocardial infarction and so on. And they include the patient with single vessel, double vessel, triple vessel disease with class 1 to class 3 angina with subjective evidence of ischemia. And the more important things was anatomy, they were suitable for the PCI. So all patients were suitable for the PCI, and there were 2 arm, optimal medical treatment plus optimal medical treatment and PCI. And the baseline characteristics were same. The aim of the trial in the optimal medical treatment was to modify a modifiable risk factor also. So there was a clear-cut goal. If patient is smoking, he has to stop the smoking, he has to maintain the lipid levels, he has to maintain the exercise level, the blood pressure level should be under control, and diabetes is under control. And for the medical treatment, all possible medical treatment were given to all the patients wherever required. And again, the more emphasis were given on the lifestyle modification in the form of stopping of the smoking, exercise program, nutritional counseling, and the weight control. And what we found out, that the optimal medical treatment was as good as PCI, and there was no difference in the death due to any cause or myocardial infarction, and overall survival was similar in both the groups. So with this trial, we could come out that optimal medical treatment with PCI is as good as only optimal medical treatment. But what they found difference was at 1 year and 3 years, the number of anginal episodes were less in patients who were randomized for the PCI arm rather than the medical treatment arm. So this trial concluded that initial management strategy in patients with stable coronary artery disease can be optimal medical treatment or can be optimal medical treatment with PCI. But the patient who underwent PCI had less episode of angina, and the quality of life is better in this kind of patient. If you see overall the literature, the patient with the low to intermediate risk group, even if you do a CABG, if you do a PCI, overall mortality is not going to change. So with this, we could not get any new information. And you see, the COURAGE trial, overall the 35,000 patients were screened, and out of 35,000, only 2,300 patients were selected. That means 1 out of 15 patients were selected for this trial. And most of the patients in this trial have the good LV function, they have the class less than class 1 angina, and the patient, anyway we know that this patient, if they are on the excellent medical treatment, they have the very good outcome. So we could not get any new information from this trial. What they have excluded in this trial, patient with a left main disease, patient with a cardiogenic shock, patient with left ventricular dysfunction, serious arrhythmia, congestive cardiac failure, complicated MI, and patient with unstable elevation MI and unstable angina, which we in our real practice see more of the patient, more than 80% of the patient we see this kind of patient in our practice. So, and this trial has suggested that more than 32% of patients underwent PCI in subsequently period if they are on the optimal medical treatment. So, if you are selecting any patient with a mild to moderate risk for optimal medical treatment, we have to be prepared, our physician has to prepare that this patient sometime may require PCI, and we should be ready, we should be open to send this patient for the PCI. If you see overall the meta-analysis, all trials have suggested that medical arm in patient with the intermediate to low risk group is as good as optimal medical treatment. So we could not get any new information in this trial, but yes, we found out that with PCI, the patient has less episode of angina, and in the realistic world, the patient with optimal medical treatment, if required, they should undergo PCI to have a better quality of life. And what we are dealing with the intermediate to low risk group, anyway, these patients will do better with the medical treatment. But what about the high-risk patient? The high-risk patient with low EF, with the high treadmill score, with stress-induced ischemia, patients should go for the revascularization. So this trial, we concluded, okay, this medical arm is as good as a PCI arm, but it should be as a part of our decision, not the only factor in deciding a therapy for this kind of patient. And we should always look for the associated factor like presence of diabetes, presence of LV failure, presence of whether there is a left main stenosis or not. Or if the patient fall into the high risk group, we should always send a patient for a PCI or any intervention or CABG. The hungry heart need a blood, not or a hungry person need only food. He will not need any evidence whether after food I am going to be okay or not. He just need a food. So looking to this in mind, the heart or myocardium which is at ischemia need blood supply in the form of revascularization. And to compare the PTCA versus CABG, we have the different trials available now. I'm not going detail into the previous trial, but all the previous trial have suggested that if you are dealing with the low to medium risk group, the PCI or CABG are equal. But when we are dealing with the high risk group, yes, of course, CABG is better than the PCI. Not to misunderstand, if you are dealing with a patient with 1 to 2 vessel disease, again, PCI is a good option until unless there is a proximal LAD associated with the LV dysfunction. Or if same patient with a 1 to 2 vessel with high risk for the PCI, CABG, again this patient should go for a PCI. Again, even the single vessel disease with left main ostium, if he is a high risk for surgery, again the PCI should be the option for this kind of patient. In the syntax trial, it's a very good trial which compare the CABG versus the PCI. Both the baseline characteristics were similar in both the patients. What the syntax was found? That CABG was far better than the angioplasty in patient with the syntax trial. But when they did the sub-analysis, they derived the syntax score based on the syntax trial. And what they found, if you belong to a low-risk category, then again PCI is as good as CABG, except the repeat revascularization, which was more common in the PCI group. Otherwise, all parameters were similar. But as we go with a high syntax score, CABG is always better than the PCI if the risk score is very high. Even the freedom trial, which involved more than 1900 patients, we say CABG is better than the angioplasty. So what is good or great thing about the CABG? Now the cardiologists realize the gold standard for multivessel disease is a CABG. Because the CABG gives a complete revascularization, sometimes when we are not able to do the PCI completely, then the surgeons can do a better job. The compliance or adherence to the double antiplatelet is not an issue with the cardiothoracic surgeon. And sometimes if the patient is not very frail, the surgical risk also not very high in this era. So again, still there are so many patients, so many physicians, they are very pro on the PCI. When CABG is so good, why we should send a patient for the PCI is so good? Why we should send our patient for the CABG? Answer lies here. See, way in the 2001, if you do a complete revascularization by either PTCA or the CABG, the outcome is going to be similar. So the key issue here should be complete revascularization. The CABG and the angioplasty is totally different aspect. If you do a better revascularization, both arms going to be similar, but at the cost of stroke. If you offer a patient with a CABG, be ready to have a predictable risk of score if you are sending a patient for the CABG rather than the PCI. Even the freedom trial also suggested that risk of stroke is more in patient with the CABG compared with the PCI. So PCI is now it's better than in fact the syntax and the freedom era because we have more novel balloon, more balloon technology available. Here, I'm not here to claim that PCI is always better than the CABG, but at our level, we should find out subsets of patients, which patient is good for PCI and which patient is good for the CABG, and subsequently we select the patient accordingly. So how to go about it? Trial helps to select the appropriate therapy for a given subset of patient. Each patient need to be individualized based on the certain parameters and ask yourself if patient is really going to be benefited with the invasive procedure or not. And always assess the risk versus benefit. Look for the clinical sign and symptom of ischemia, whether this patient is really need something, and look for the objective evidence of ischemia. You can do a supervised TMT, you can do the dobutamine stress, thallium scan, and then you decide whether this patient can be better on the medical treatment or he really need an intervention. And again, think for the complete revascular, which is the key. And the functional assessment, even when I do the angioplasty, I feel, okay, this lesion is not very critical, don't require angioplasty. But if I have the FFR, I can assess the probable the significance of the lesion, and if required, I can do the angioplasty of that particular lesion also. So which procedure is appropriate? The discrete lesion is probably in the, all the three vessel. If I know that I can do a better revascularization, I should advise a PCI to that patient. But if there is a discrete lesion in 1 to 2 vessel, with third vessel is CTO, then I should not be advising angioplasty to this patient because I am not doing the complete revascularization. And that patient, CABG is the choice. If you find it difficult or diffuse TVD, TVD with the severe MR, or you need that, he will need an aneurysm repair along with the CABG, definitely this patient should go for the surgical intervention rather than the PCI. So what is the key? Not only the treatment by PCI or CBG, again you have to emphasize patient on the lifestyle modification, and he has to be on the aggressive medical treatment, whether he is on PCI arm, whether he is on the CABG arm. So here I would say the cardiologist and surgeon should work as a team without their ego. Each patient should be individualized, family should be counseled, all possible options with pros and cons should be discussed, and decisions should include the socio-economic status also, symptoms class, coronary lesion anatomy, and associated comorbidity with the surgery. So the key question here is, I should ask myself whether I can do a good job or my surgeon can do a good job. If yes, I can target a lesion, I can do a better revascularization, I can skillfully do the procedure, then I should be selecting the PCI or CABG, whatever appropriate for that particular patient. And I should keep the, what is the goal of doing this intervention, whether patient is diabetic or non-diabetic, whether patient can adhere with the double antiplatelet therapy or not. If patient belong to a high risk category, then I should not be sending for CABG. And what is the ejection fraction, whether this patient is really having the mitral regurgitation or not. So if you look all these parameters, I think your selection, your sending a patient for appropriate therapy will be okay. So PCI and CABG for multivessel disease in the presence of LV dysfunction in 2015, what I will recommend, multivessel disease is a very high risk category group. We have to handle this kind of patient very carefully, very promptly. Functional assessment and the coronary anatomy is very, very important. For true multivessel disease, take the patient off the table to objectively assess all the options and take the honest decision whether this patient can do better with the medical treatment or better with the PCI or better with the CABG. Thank you so much.
Thank you very much. Any questions, please?
Surgeons have said, yes, you need a CABG. They went to a cardiology. They said, no, I'll do a multi-vessel angioplasty. So your one sentence important that there should be close correlation and work as a team.
Yes, sir.
Which never works in a private sector.
No, sir, in our hospital it works.
No, yours may be exception. I'm telling of a generalized, I know a lot of private sector.
Yeah.
And then whether it should be done or not, there is no correlation. Everybody thinks whatever he wants it.
Yeah.
Where too much money involved is always
No,
a
sir.
problem.
Actually, what I do, I apply the mother and father rule. If I am in doubt whether this patient is good for CABG or angioplasty, I always ask, if this patient is my mother, what I shall do? And your answer will be always correct. So, I don't think money can be the driven factor for deciding the patient's decision. Yeah, I also see, then I feel very, very bad about this.
Could I say something?
Okay.
Even in private practice in UK, you are expected to have a multidisciplinary discussion on this matter.
Yes, yes.
Document what you have discussed fully in such a way that this is what cardiologist said, this is what the cardiac surgeon said, this is what third person said, right? Then decide how you're going to proceed, justify that, then go and justify all that to the family and to the patient and document that you have done so and get on with it. In other words, there cannot be difference in the way you manage, whether it is in private or in National Health Service. That's the first. If that is found to be not carried forward, the person will be in trouble. That is the message GMC have given to every doctor. You document everything, make multidisciplinary discussion and document it.
Yes, thank you.
Thank you. Thank you very much.
Dr.
Yeah, please.
Satya, you had discussed at length management of stable angina.
Yeah.
What percentage of patients do you think of stable angina would be having triple vessel disease with low EF?
No,
Because that was your topic, TVD with
Yeah.
low EF.
So mostly when any patient present with the low ejection fraction, we try to evaluate the coronaries. Almost if symptoms suggest more than 50% of patients have the coronary artery disease underlying. So
Presenting with stable angina.
yes,
With low EF.
yes.
Anyone
Okay.
else have any
Unless we
comments?
are idiopathic cardiomyopathy, it's a different issue, but yes.
Okay, fine. Can that be the
Thank you
case?
very
Thank you
much.
very much, Dr. Gupta.